You know, as I head this wonderful organization representing a life-saving industry here in Massachusetts, I really have a hard time reading the headlines sometimes. You know, I can't read about a $1,000 pill without needing to explain how in the long run that pill can cure a public health epidemic. I can't listen to a story on growing healthcare costs without wanting to explain that prescription drugs are the only piece of the healthcare system that has built-in price reductions as a result of generic competition. But I know that the business that we're engaged in, as you've heard today, it's the messy, risky business of discovery, development, and commercialization. It's not easily explained in sound bites or infographics. It's only through deep and sustained dialogue with all of the stakeholders that we'll be able to explain that supporting an ecosystem that rewards innovation truly is a matter of life and death. You know, today's one conversation in that dialogue, and I want to welcome experts representing two other pieces of the healthcare system up to the stage with me today. First, Andrew Dreyfus, the president and CEO of Blue Cross Blue Shield of Massachusetts, which represents 30,000 employers and 2.8 million members. Wow. Wow. And also Sarah Iman, Chief Operating Officer for ICER, the Institute for Clinical and Economic Review, whose new value framework is earning some headlines all on its own. So I want to thank Andrew and Sarah for joining us all here today. I'm going to join you. It's not really going to be a moderated discussion. I like this panel so much, I asked if I could kind of kick it off, be the moderator, and sit on it. And I'll represent the MassBio democracy, right? I'll represent manufacturers, and I'd like to just bring the patient advocate piece of it. One thing that providers and payers and innovators and manufacturers, what we all agree, we're doing this because we care about sick people. Mm-hmm. And that's why we're having this conversation, because when you look at the title here, the Balancing Act, access, quality, cost of healthcare, if we don't have new therapies and if we don't have a way to pay for them and if patients can't access them, you know, what the heck are we all doing here, right? And, you know, to the elected officials out there, who do you care about? You care about your constituents, right? And those are the patients and all the folks from disease foundations that come to visit you. So, you know, I'd like to start it off. And Andrew, why don't you first, you know, give some opening remarks and talk about some of your challenges and what's on your mind, and then we'll move on to Sarah.
Great. I think Attorney General Healy kind of framed the issue really well. We have these life-saving treatments, but right now they're at a cost that we often can't afford. And let's be clear on both, that lives are being changed in a way that were unimaginable a decade ago, but the spending is something we're all concerned about. And healthcare affordability may be one of the most important economic issues in the Commonwealth. You heard Secretary Sutters refer to the percentage of state healthcare spending, the state spending that's devoted to healthcare. You know, as employers, and many of you are both employers, and thank you, customers of Blue Cross, you know what an important part of the cost of your own employment are your health benefits. And finally, for individuals, they're bearing a greater and greater share of the cost, whether they're buying the insurance themselves or whether the percentage of healthcare spending. So it is a major problem. The state has established a benchmark through which healthcare spending should grow only about as fast as the economy, and it's been around a little above 3%. And the largest amount of spending, which is on hospitals and physicians, has actually been controlled at or below that amount. But the spending on this sector, on pharmacy, is growing much more rapidly. And it's the fastest growing portion of the healthcare spending. And within pharmacy spending, of course, spending on specialty drugs are growing the fastest. We've had some discussion about Sovaldi today, and an important discussion on the opioid epidemic, which Blue Cross is playing an important role in as well. But I want to talk just for a moment, just to give you an example of another class of drugs that many of you are probably familiar with, the so-called anti-TNF drugs, the anti-tumor necrosis factor drugs that are used to treat inflammatory diseases like rheumatoid arthritis and Crohn's disease and psoriasis. Until the advent of Sovaldi, these were the highest spending drugs on our formulary. But for Sovaldi, they are still. Now, a decade ago, there were just a couple of drugs. You're familiar with them: Humira, Enbrel, Remicade. Today, there are 16 or so drugs in this category, of which Blue Cross actually pays for most of them, I think 13. But what's interesting is, even though more drugs have been introduced, spending on these drugs has grown rapidly. Why? Well, partly because there are new indications for the drug, and that's a good thing. And again, these drugs are actually changing the natural history of some devastating chronic illnesses. But the price of these drugs continues to grow. So competition has not reduced the price of the drugs, and overall spending has grown. And so we have to start asking ourselves questions about these drugs and other drugs, and I know you'll hear from Sarah in a moment about this. Can we get to the question of value? Can we talk about how much we're paying for drugs versus what kind of value they're providing for patients? Let me just stop there because I know we want to have a conversation, but more to come on that.
Absolutely. Sarah?
Thanks, Bob, and thanks to MassBio for hosting this breakfast and having me. I'll start with why am I here. Many of you are probably wondering, so ICER is this small nonprofit that does nerdy comparative effectiveness research, and so why am I at the NBC Policy Breakfast? Well, last year we launched a program where our goal is to do 15 to 20 reviews a year of new drugs at or near the time of FDA approval to first answer the question of, does it work? Is it better than what we already have out there? Does it represent an innovative cure like Sovaldi, or is it just as good as what we're already doing? And then ICER has a mission that's committed to answering the second question, which is what value does that bring to the system? And we balance long-term benefits to patients in terms of cost effectiveness. Attorney General Healy very eloquently mentioned, you take into account the avoided liver transplant for the patient who gets Sovaldi now, and what are the other benefits that society reaps from investing in cures. And then we balance that with the short-term budget impact that systems need to face because we have to figure out how to pay for it. And ICER's mission is really dedicated to improving the conversation about what is value and how do we answer the question of is this better than what's already out there, and how will we pay for it long term? I think the other piece is that ICER, and why we've gotten a little attention, is that sometimes the calculus shows that the prices that are set by manufacturers are out of whack with what the long-term value and the short-term budget impact are of those drugs. And then sometimes they're not. So I'll give two quick examples, because we did get some criticism in the beginning that we were about saying that drug prices are too high. That's absolutely not at all our goal. Our goal is to try and decide what that value-based price benchmark is. So we looked at drugs for high cholesterol, a new class, PCSK9 inhibitors. Fantastic evidence of lowering LDL cholesterol. No evidence yet, it's coming, on what the long-term effects are on avoiding cardiovascular events, heart attacks and stroke. So we looked at those drugs. Their average list price is $14,350. When we did our analysis, both of cost effectiveness and budget impact, we assumed that the price at which you would have to price the drug in order to not have a lot of managed utilization, prior auth and other things along those lines, is $2,100. It's an 85% discount off of list price. Then we looked at a new drug for heart failure called Entresto. Entresto's list price is about $4,500. We did the analysis on cost effectiveness and budget impact, and we found that the value-based price benchmark was $4,900. So you'd need it was the other way around. It's $4,900 list price, and the benchmark was $4,500. And so it would be a 9% discount off of list price for that to meet the value-based price benchmark, which you guys all know is well within the average rebates that are usually offered through the system. And so for us, it's really about bringing an academic approach to looking at the evidence objectively and being able to make a judgment of, does it work better than what we already have, and what kind of value does it represent to the system?
A lot to think about, huh? One of the things that I just wanted to bring from a perspective standpoint, is the father of a 13-year-old kid that has cystic fibrosis. I've watched, and seen how much he costs. And it's expensive just to stay well. The chest physical therapy, upwards of 100 pills a day in pancreatic enzymes just to digest food, couple nebulizers a day of tobramycin or pulmozyme and hypertonic saline solution, and hospitalizations, cleanouts that really cost a lot. And then you see how far a company like Vertex, for example, has come with the CFTR modulators, Kalydeco and Orkambi, and and people say that they're expensive, and they are expensive. But how do you account for the fact that it's replacing a hospitalization this month, next year, the following year? Would it stave off or prevent a liver transplant or a double lung transplant that gets real costly? And I just feel as a patient or a patient advocate consumer, it drives me nuts when I see that a drug, people talk about a drug being so expensive, when in reality, I know that it's going to save money in the long term. And hey, and let's not forget, it's going to save his life. So, that's the stuff we're dealing with here. So as a payer system, like, what can we do? Like, what can we do to track it? Or what do we need to do?
Yeah.
Because it is expensive. And it wasn't a big deal at first because it was only 4% of the population. Now you're at to 50% of the population. The next one's going to get it up more, and that does grow exponentially, the cost.
So you guys know how lucky you are to have Bob, right? Just make that clear. He's a great advocate for your interests and a great executive for MassBio. You're absolutely right, Bob, that there are new agents that are coming on the market, and Sovaldi is actually a good example that probably long-term is going to save money. I mean, it depends what price point and a lot of projections. And that's why companies like ours are covering Sovaldi, because it's changing lives and covering some of the cystic fibrosis drugs you're talking about. But those aren't all the drugs that are coming onto the market, and some actually provide a modest benefit over existing therapies. And that's where we need analyses like what ICER is doing to examine the value question. So where are we getting a huge benefit and we ought to pay for it? And where are we getting a more modest benefit? And in terms of the huge benefit and paying for it, as the Attorney General said, are we being sufficiently transparent about what some of the costs were to develop those drugs, and knowing that that's a extraordinarily complex undertaking, and as we all know, you're working on scores of drugs when, if you're lucky, one or two kind of come to market. Sometimes we have to look at the question of what indication is the drug for. Our pharmacy benefit manager, Express Scripts, is looking at a new idea called indication-specific pricing. So take the drug Tarceva, which is a breakthrough drug for lung cancer patients, can extend life on average 6 months, which is huge for a lung cancer patient, having had one in my family. But it's now being applied for pancreatic cancer, where it may extend life for a few weeks. So they're actually looking, do they price it differently for those two? Because the value is much greater for the lung cancer patient than the pancreatic cancer patient. But back to your example, if it's your family member who has the cancer, you want to do everything you can to extend life. So we have to start asking some of those difficult questions.
And I'd like to add that one of the ways that we hope that the ICER framework can help inform the conversation is to help the manufacturers and the innovators understand the value calculations that my group and others are taking on as a way to help drive your drug development. So if you are making decisions about assets to continue through the development process, and you're understanding from the early data on the sort of incremental improvement that it's bringing to what's already out there, then we hope that's spurring and rewarding innovation of truly breakthrough new innovative therapies. And so we hope that it becomes part of the conversation, and it's not this hammer that comes down later and is in a vacuum. And one other point I want to make is that we're also very interested in feedback. We're going to be launching a program of engaging with different stakeholders, including the life sciences community, to help us make sure that the framework that we've developed, our version 1.0, is really answering the questions we want answered. And so I'm going to be working with Bob
Yeah.
on making sure that we have MassBio's input on that, because that's an important part of this, is having that conversation.
Yeah, and that's a good point, Sarah. I mean, I'm not going to quote anybody or use any names, but I've heard from member companies that think what you guys are doing is not going to be good. And I've heard from some people that have gone out there on the limb and said, hey, maybe it's what we need. But how best, I think a couple of the questions we want to answer here is how, as industry, what do we need to do to work with you to make sure that, in our opinion, you get it right? Doesn't mean he's going to agree with you,
No.
but we want to, and he can have his way of
We might
dealing
not
with it
always
too.
agree too.
But,
That's right.
But we want to make sure that these long-term costs that are avoided are captured.
And sorry, go ahead, Andrew.
Well, you know, I want to also look at the flip side, is this idea of applying a value-based framework to spending on drugs. We can look at it from the other perspective. Let's look at low-cost drugs. So let's look at low-cost drugs for chronic conditions. Maybe those drugs should have no cost for patients. And so we're starting to design value-based products which guide our members generally to lower cost settings for healthcare. So for example, maybe a lower cost community hospital rather than academic medical center, maybe a freestanding imaging center as opposed to an imaging center at a hospital, and maybe a generic drug for a chronic illness in which the copay is zero. And so, because we have to look not just at the cost to the system, but to the cost to the patients, and how do we encourage and engage our members, patients, in their care such that they're compliant? Because we talk a lot about the cost of drugs, but you know, one way to get the cost drugs is to get the cure or the treatment quicker and consistently. And adherence, you know, is a big challenge in our field generally that we share. And one way to improve adherence is to lower, in some cases, the cost to the patient.
I want to build on that if I could, because I
Yes.
think that there's, we've seen the increase in the high deductible health plans that consumers are using. So if we look at this from the patient perspective, patients are clamoring for information about how to spend their healthcare dollars more wisely. And it's really been difficult for them. The Health Policy Commission report just came out on cost trends and has highlighted that even though we've had, you know, legislative impetus to try and have transparency from hospital prices to MRI prices, and the health plans have taken the lead on this, it's still really hard for consumers to know how much their care is going to cost. And so we hope that having this framework and having these value-based price benchmarks helps patients with those choices as well in a value-based insurance design setting. And the other side of that is that the more you empower patients to have the information that they need, the more it can drive policy that can help reward the innovation that brings something to market that is a high value and better than what's already been out there. Some of the policy ideas that we've had based on our framework are, well, what if you develop a new drug, it's much better than what's already out there, it's priced appropriately, and it delivers a great value to the system. Fine, put it on first tier with no copay, like Andrew mentioned. What if we extended your patent life? What if we delayed competition? And then the flip side could be, well, if you get something out there that has not that much better efficacy and it's way overpriced than what we're already using, then maybe we introduce competition quicker and we shorten your patent life. I mean, so there's a lot of policy tools that could be put out to try and innovate on both sides to reward the development of drugs.
Bob, can I bring in the other key participant in the system we haven't talked enough about is the physician who's actually doing the prescribing. And so I think you know another big initiative that we've had over the past 7 or 8 years is changing the way we pay for care more broadly, moving away from fee-for-service payments, paying for each encounter or visit or discharge or admission, and instead paying on what we call a global basis, a fixed amount with incentives for quality and outcomes. That kind of payment system, which is now in effect for all our HMO members and increasingly for our members who choose a so-called PPO product, and we have now about 90% of the primary care physicians and specialists in the state participating, it puts the conversation back where I think it belongs, with the patient and the physician, and for the first time in a long time starts to put some of the onus back on the physician to think about these value questions. Because, you know, especially several years ago, if you asked a practicing physician, and Dr. Dimitri could probably validate this, Do they know what the price of the drugs they're prescribing is? They often didn't. And first of all, what is the price? What is the cost? And then what is the cost to their patient, which is maybe the most important thing in the short term to them. So we need to get that information not just in the hands of the public, but in the hands of physicians, and ask them to consider some of these broader questions as they're making treatment decisions. We always want the treatment decision itself to be in the best interest of the patients, and I know all physicians do that. But sometimes there are two choices which are equal from a clinical effectiveness perspective, but one is very expensive and the other is less expensive. Physicians ought to know that. Patients ought to know that. We ought to understand that as a system.
Okay, well, let's touch on a couple other topics,
Yeah.
and then we'll have time for questions. But transparency, okay? What are we talking about? You know, it seems like in Massachusetts, it's a different issue than when I go down to DC. I was down at an event with you, and they were talking about transparency, but they meant something totally different than what we were thinking here. So I just want to talk about it.
Right.
Okay? Transparency. Is this, you know, into our industry, an area where we need to get a little bit more squared away? You know, one day we're talking about a drug costing several $1 billion and taking forever to invent, and that's why drugs are expensive. And then the next minute we're saying, well, that's not how drug pricing is done. It's based on value. Value meaning what the existing treatment is and what more benefit it brings to the system. And I think that's what you're talking about, right? That's what ICER wants to do, is really develop value. Now the transparency piece, people are saying, well, we need to know exactly how many dollars went in to creating that drug, so that then what? That means we know how you're going to do what you do, or you're going to price with the, work out the price with the manufacturer. Like, I don't get what that transparency does to help a patient or get access to a drug. And then on the other hand, we're talking about transparency, like what are the rebates? Like, we hear about this list price, and then these reports come out with based on list price, and then people say, yeah, but nobody pays list price. Everyone gets a rebate or a discount. Is that the transparency we're talking about? I don't know. But I think it's important that everybody in this room knows I'm very confused.
You're not
And this is
alone.
what we're trying to fix. So
Right.
Yeah.
let's have this. We should have like a fire. There's a real fireside chat. I'm like pretending they're not even here. All my bosses are here, and I'm saying, I really don't know what I'm talking about. But I don't.
You're not alone.
So let's fix
no,
it.
No. So you're not alone, and transparency does mean different things for different people. I'll tell you, the piece on the rebates is really important to mention, because one of the biggest criticisms of ICER's framework has been that we do our comparisons to WAC, the wholesale acquisition price, the cost. You guys all know that nobody pays WAC, and so, but no one can tell us what anyone pays, and so we're left with no other number to use as part of our calculations. I would love to know what the actual discounts are and what the rebates are and what you're actually giving, because then I can do the calculation based on that. But in the absence of clarity on what the rebate rates are, I have to go with what's publicly available,
Which nobody pays.
Right.
which nobody pays.
This is confusing.
Well, Bob, you know, I share, and I think we all have to share to some extent your frustration. It is both a kind of arcane world and a world which we don't have great visibility into it at all times. What I think we can be pretty sure of is that government's going to play a bigger role in the kind of pricing of pharmaceuticals over the next decade, and we're kind of at the cusp of a great debate over the next several years that won't be resolved quickly. But I think in healthcare we know that we all live with a lot of government oversight and a lot of it market force. And I think we all think there is a balance that has to be achieved between those two, and we live with it as a health insurance carrier every day, and physicians and hospitals live with it too. And I think in the biotech and pharmaceutical world, there may have been a little less of that oversight than there has been in some of the other sectors, and I think it's going to increase over the next few years. And what we have to do collectively is work to make sure that a balance is achieved that still rewards innovation, rewards discovery, rewards scientific research, but the other hand gives those purchasing the fruits of that research greater comfort and greater sense that, you know, they're providing value. And obviously the government is both a regulator and a major purchaser, spending about half of, you know, the healthcare dollars between Medicare, Medicaid, and Defense Department spending, and they're going to ask for greater transparency, and so it is coming. Government's also a major funder of, you know, biomedical research, and so they have a stake in it from that perspective.
Absolutely.
And so we're going to be evaluating and working on this rebalancing over the next several years.
I wonder if we could all work together, our industry and your industry collectively, to come up with what we really think the definition of transparency is.
I think that's
Because
a great
there's
idea.
two totally
Right.
different, and I think that'd be a great step. And
That'd be a
then,
great step.
one other topic that I think we have a couple minutes to talk about. If you think of the amount of innovators in Massachusetts that are working on, whether it's gene therapy, I'm talking like breakthrough innovation, gene therapy. You look at what we have going on in molecular diagnostics. I mean, how are we ever going to really have personalized medicine if we don't have the diagnostics that go along with it? Now, how do we prepare for the future? I mean, there's sometimes where I say that what's happened with Hep C and these wonderful, amazing cures that have come to market to help these people, I think it's a blessing in a sense that it's forcing us to have a discussion for things that are coming down the pipeline. We hope, because that's what we do here in Massachusetts. We want to invent non-addictive opioids. We want to cure diseases with gene therapy. We want to have the best diagnostics so that we can implement precision medicine. That's what these companies are doing. But I guess the question that industry has for both of your organizations is, how do we work together so that we can really make this happen? Because otherwise, like I said earlier, there's no sense in doing it, right?
Yeah, can I say, I don't know is the answer to how do you pay for the gene therapy in vitro that cures cystic fibrosis? I don't know how you put a value on that. That is going to be a very big societal conversation that we all have to have as grown-ups. And I want to be part of that conversation. ICER's framework, probably as it exists, isn't really appropriate for those curative, multi-million-dollar therapies that have been more thought exercises than anything, but not forever. And so I think it's fair to say that that's a really tough question that a lot of smart people have to get together and try and answer.
But that's why I invited you two to sit on the panel.
Did you see how I passed the buck there?
Yeah. Come on, Sarah, that's why you're here.
But it's true, because it is a big question that needs a lot of societal input.
It is a big question, although I have kind of confidence in our collective both willingness and ability to kind of wrestle with that question. And personalized or precision medicine is coming, and it's kind of upon us, and we've already seen a few great breakthroughs in that area. And as we understand diseases like cancer and others differently, we're going to have to find a way to fund it. But again, I kind of bring us back to the overall affordability question, is that healthcare generally is consuming a greater share of government budgets, employer budgets, and family budgets, and we're going to have to be very cautious and only pay for those treatments that we know will be effective and hopefully curative in some cases.
Yeah. And again, we laugh a couple times up here, but these are serious issues, and I just want the crowd to know that it's wonderful. We're lucky to have you as a healthcare leader in the Commonwealth, and your company truly is the benchmark for private payers here in Massachusetts, and I appreciate what you're doing. And Sarah, too, I know it's not always popular in this crowd to do what you do, but the same way I go to your events and sit in the hornet's nest and talk about this stuff.
I'll come anytime.
This is really what we need to do. And I think one of the things that I'd ask maybe that you and I could do, if maybe a couple members of the MassBio board and a couple members of your board or industry representatives maybe form an advisory group so that we can figure out how we can partner together to do things that we can bring develop solutions that we can bring to our partners in government so that we don't need to continue to file legislation for this or that and put the onus on the elected officials that have a lot of other things that they need to do. I'd like to do that.
I'd certainly be willing to commit to that, Bob, and I'm sure the other health plans in Massachusetts.
This could be landmark. We should shake
right,
on
right,
it.
Right,
Want to get a picture of this?
Right.
We just agreed to solve a problem that we don't know how we're going to solve.
Right.
But no, that's important. How about questions from the audience? We have a couple more minutes before we're going to start wrapping up. Somebody has to have a question out there.
Yeah, right.
Yes, sir. Is that Ted?
I'm shy, yes, of course I have a question.
Can we get a microphone over there?
Thank you so much. Ted Buckley from Shire. Question, does ICER take into the fact that eventually most of these therapies will have generic competition, will become genericized, et cetera, when they're thinking through the value of the product to society?
So when we do the cost effectiveness analysis, it can take the time frame that we use varies depending on the intervention. So if we take a lifetime time frame, we factor that into the long-term cost of the drug, and so we'll build in inflation costs based on how much drug prices have risen year over year for an existing drug, and then we build into it what happens when the patent expires. When we do the budget impact analysis, that's only a 5-year time horizon, so that doesn't take into account the fact that it will go off patent because it will be the full price of the pharmaceutical during those 5 years.
Okay.
We can talk after. It looks like you have more questions. I'm happy to chat.
How about generics? Are you seeing a rise in the generic pricing?
We are. So I'd say
Because that screws up what we're trying to do.
Right. We start out, by the way, as a state with a very high generic substitution rate, and that's been one of the ways we've generally been able to hold spending on pharmaceuticals over the last decade to a relatively low level. Now we see this rise, especially driven by so-called specialty drugs. But there are some instances, some well-publicized, where even generic drugs have started to increase their price and cost to the system substantially. And so we should not just focus on these new breakthrough agents. We need to focus on generics as well, and we need that kind of transparency that we talked about applied in that area as well.
There we go, another type of transparency.
Yeah, right.
Can add that to the list.
Right.
Any other questions?
They want to go home.
Everyone wants to check their email.
Right.
Yeah. Okay, we don't see any other questions. How about some closing remarks? When are we going to form this group? When's our next meeting?
Right.
How about next Thursday?
That's sure, it's good for me. I want to just thank you all again. Bob is right that there are many members of industry who have not been very excited about the advent of the value assessment framework, but we really truly are interested in feedback and advice on how we can improve it. And I want to make a note about we really do drink our own Kool-Aid. When we do a new appraisal, we've just started one on multiple myeloma, we contact every manufacturer of every drug that we're studying. We hold conference calls with them. We share preliminary results with them before we release them publicly. And so it is part of our commitment to be able to engage the manufacturers, and we want that to continue.
I would just add a final comment. I think it was the Attorney General who said if she asked for a show of hands around the opioid issue, we'd all raise our hands saying that we knew someone who was involved with that. But if we asked a different question, if we asked, is there someone in our family or at work or a colleague or a neighbor who has benefited significantly by the advent of a new agent that's come on the market, we'd also all raise our hands. Mm-hmm. So you all are doing extraordinary work, and I want to thank you for it because patients everywhere are being helped, and it's now our assignment, and now we have a formal agreement about it, to work together to make sure that the benefits of these breakthroughs are available to everyone in the Commonwealth and everyone nationally at a price that we can, as a society, afford.
Okay, how about a big round of applause for this panel? Thank you, guys.